Good morning, children of a lesser joint, and welcome to today's version of Jaw Talk. This is part 6 of Can the Lateral Pterygoid Muscle Cause Disc Displacement? Thus far in this lecture series, I've tried to present information which is based on evidence-based research that it is less likely the lateral pterygoid muscle is responsible for disc displacement. Today I'm going to be talking about a prosthodontic term called centric relation, and I've given it a controversial title, Can It Be the Great Mistake? Centric relation is part of the terminology we use in dentistry to describe condylar position. Part of the rationale behind the treatment associated with temporomandibular joint dysfunction and disc displacement came from the reciprocal relation of the lateral pterygoid muscle between the two heads, the superior and the inferior head, meaning that they were active during opposite movements between opening and closing. In centric relation, from a prosthodontic perspective, we establish this as a priority. Centric relation appears in the literature probably somewhere around 1929, although some of the discussions that occurred before that I've traced back to 1918. And it is an important issue in dentistry because the need for a condylar position became very apparent when we were storing patients that had no teeth. So a lot of this comes from dentures. In that case, the teeth didn't serve as a positional reference point. And so establishing a position that was repeatable, and we were able to take that information and place it on what we call an articulator, a device that simulates jaw movements, although poorly, but that's what it's used for, so that dentures or partial dentures could be made for patients. The terminology centric relation helps us to establish the priority as the most important position in transfer of information in edentulous states without teeth to an articulator. Within the population, if you do have teeth, there is always a difference in the position of the jaw joint or condyle in its most superior and anterior position, as now established as an accepted term for centric relation, and the tooth position. So that when you go to check the condylar position, what you find is that the last tooth almost always hits before the rest of the teeth, and there is a slide forward. And so that slide now became the scapegoat for implicating the lateral pterygoid muscle and contributing to disc displacement and temporomandibular joint disorders, because this tooth, after it hits first, in order to close all your teeth together and have them hit at the same time, the jaw will slide forward. And because the motion was forward, it was believed that the lateral pterygoid muscle was responsible for this. It then would be forced to hold the teeth in that position, creating a tractional force on the disc and ultimately creating the demise of the condyle disc assembly. It is still taught today in a lot of the teaching curriculums and perhaps in some of the dental schools, although I'm a bit away from having graduated 40 years ago. But this is taken from the Spear Educational Institute, and recently, you can see the date, May 17th, 2017, where they talk about the slide from centric relation to the maximum intercuspal position. And here are the pictures that go along with this particular blog article, given by Dr. Sandhu, who's a member of the teaching faculty at Spear. Another member of the faculty is Dr. Gregory Kinzer, and he shows a technique that we use in order to evaluate the condylar position in its optimized place, called centric relation, using bimanual manipulation. I'm going to show you a video of that shortly. And here's an article by Dr. Palacecar for those of you who are dentists and would like to read a nice little article about the historical and contemporary perspectives related to centric relation. Nice little review. This is a video that I got offline, and I want you to see how we as dentists visualize this when we're evaluating our patients to see if there is a difference between centric relation and the intercuspal position. So here's what it looks like if you're using this approach. Notice how the hands are positioned with what is called bimanual manipulation. And we jiggle the jaw. This does take a bit of time to master. And notice there is a first point of contact. This is going to loop a few times. The first point of contact is when the last tooth hits, stop, and then we ask the patient to close, and you can see the slide forward. I'll have them do it again. There's a bit of jiggling, and now they're going to put in articulating paper into this position, and that articulating paper will act as carbon paper, and they'll mark the first point of contact, and this now becomes potentially a source of treatment in order to alleviate the discrepancy between the condylar position and the tooth position. And it becomes, of course, part of the treatment that may be used to resolve the problem or purported problem in causing temporomandibular joint dysfunction. Now, the real question here is that an abnormality? Because within the normal population, you almost find that centric relation and the intercuspal position are never the same. Reports of this range from 90 to 100%, and in my practice, I would tell you when I used to use this as an approach to treatment and evaluation, it was always 100%. So I question whether or not the 90% is really a valid answer in the metrics of this. Now, in order to see if I can generate a little bit of interest here, I'm going to use a phenomenon described by Ulf Posselt in 1952. It's taught in every dental school in the world as far as I know, and it's called Posselt's envelope of motion. And what we're going to see next is a 3D recording of what that looks like. Now, this is a human that's actually been digitized by the Saunders company, And I've shortened it, so you're only going to see a portion of this so you can get an idea of what Ulf's Pastel's envelope of motion looks like. This is somewhat of a 3D animation, and it's no more than a recording of the movement that is made of both the mandible and the condyle by doing a recorded tracing of the pathway that the edge of the lower incisor takes. So here's what it looks like, at least a little bit of this. Now that's the sagittal plane, the side view, and you start to see how the lower incisor and mandible move, and it's going to talk about some of the reference points that are made during this recording. So this is the full architecture of motion that's occurring here. And again, we're following the lower incisor. And I'll let this loop a few times. Now, there are some things that are going on here that you should be aware of. Notice, at the time of closure, I'm going to let this loop one more time. Let's go back. Notice at the time of closure, the second molar is going to hit first. I'd like you to watch that occur. Hit and slide. What most people don't realize, even the dentists, is that at the same time that this tracing is recording the motion path of the lower incisor, it's also capturing the condylar movement. So now what I'm going to do is I've taken a section of this and I've slowed it down to 33% of the normal motion. And I want you to take a look at several things. This is going to loop several times so that you'll be able to focus on the different portions of this so you'll understand what I'm talking about. Okay, here we go. The hit and slide, the hit and slide. Notice how that's occurring. That's part of the normal architecture of motion. But what also is occurring, in addition to the motion of the lower incisor, is watch the condyle, because the condyle is actually somewhat rocking and it's coming down just a little bit as the mandible is coming forward. So there's somewhat of a rotational movement that's like a rocking horse coming down and forward. Now this is rather important because this is really the normal architecture, and it means that the tooth relationship is not coincidental with the condylar relationship in an optimum position. And again, because they saw the lower jaw come forward, and of course the teeth on that, they thought that this was due to the lateral pterygoid. But if you take a look, the motion of the condyle is not in a forward plane. It's not really moving forward. Notice how the coronoid process over here is arcing upward while the condyle has a minimal amount of movement in somewhat of a downward rocking horse motion. If I look at the straight line representations and the arcuate functions that are going on here, the place that I want to look at, and this is old terminology, where this is the retruded cuspal position and this is the intercuspal position. So this terminology is older. We no longer use that. in dentistry, but we're following the lower incisal edge path. And it tells us several things. However, if I go ahead and I draw adjacent to this the condylar path, and notice how I've made the condyle in green. Here's the condyle in my little stick figures. The lower incisor is the white ball. That the centric relation position is different when we talk about the tooth position versus the condylar position. So if I go ahead and I take a look at where the condylar position is in centric relation, okay, here are the different points established between my tooth position, and remember, centric relation is independent of the tooth position. Notice how the condyle in centric relation is higher. It occupies a more superior position. Yet, it is the lower incisor that has not reached final closure yet, and so it's not touching. When the lower incisor reaches its contact point with the upper incisor, notice what's happening. The condyle in green in a full closure position comes down. That is significant. It has a very important meaning which has not been established in dentistry. Additionally, the slide is present in almost all individuals in the population. Here is that slide. Notice how I've enlarged it on the next slide over here. So here we have the slide of the tooth, and I'm on the next slide. That is what is normal in the population. And so what we see in the intercuspal position where all the teeth are touching, that slide is actually the unloading mechanism of the temporomandibular joint. If I go back and I take a look at this, notice that this condyle is closer to the bony structure on the posterior slope of what's called the eminence. This is a loaded position. In dental terms, we call it a border pathway position. So it tells me where my joints are loaded, being closer to and bracing against the bone as it's going to go through any one of a number of movements or motions, that this condyle can be supported by the bone. This is, again, a loaded position. So when I'm talking about joint loading and unloading, I'm talking about the difference between two positions. First position is when the joint is moving. That's when the condyle or jaw joint is loaded. When your teeth come together, it is unloaded. So here you can see that these stick figures again represent actually what is going on. In the right portion of this, in centric relation, I have a loaded position. I don't want my condyle in a loaded position all the time. And the reason I don't want it is because it puts stresses on the cartilage and the disc. However, the truth of the matter is we spend almost all of our time with our condyle in a border pathway position or loaded, because we spend most of our time at rest. We do not spend most of our time over here with our teeth together. Yet it is essential for us to come together with our teeth during functions like swallowing, but also from a vascular perspective behind here, which I've yet to get to in later episodes of this particular segment, in order to empty our venous blood flow supply. So it does serve a functional purpose. But I need to have the two positions. Physiologically, it's very important. And so we establish what is a normal function as a pathologic one. Additionally, it exists in every type of occlusion. There is always a differential between the intercuspal position and the loaded joint condylar position we call centric relation. They are almost never equal. This is a study shown by Frank Cordray. It was not meant to be used for the purposes I am using it. He wanted to demonstrate that, in fact, there is a differential, and from an orthodontic perspective, he wanted to optimize treatment. And so his patients were evaluated for a discrepancy between what we call centric occlusion or maximum intercuspal position versus a loaded joint position. 100% of them had a differential. He got that right. That's exactly what I found in my practice. And in my practice, when I used to evaluate this, we use a little grid recording device to be able to demonstrate that, in fact, there is a differential. And if you notice on his study, he finds that 66.7% of his patients had a condylar displacement that was below centric relation. And so here's my habitual position. Notice how it's below the upper position of centric relation, and backwards, posterior and inferior. So that's exactly what I had found when I did it on my particular patient. And here are his mounted models when he records the centric relation position. And you notice that the second molars are hitting first. And so, of course, my question is, why do you think nature made so many mistakes? Well, nature didn't make a mistake. It's our interpretation of this. If you want your joint to have the capacity to unload and get a little relief from the stresses and strains of a loaded position, you have to let the patient slide. This is not an abnormality. So what muscle does do that? But before I tell you that, just to add a little icing on the cake, the phenomenon of sliding, as well as having both a loaded and an unloaded joint position, occurs in all species and taxa associated with herbivores or omnivores. This is an article by Claire Terhune on the instantaneous center of rotation. So this may be part of nature's master plan. Now, the architecture of motion is not the same across species and taxa, but there is a necessity for both a loaded position and an unloaded position. And within the architecture of motion, there are differences with different species and how quickly we move into different positions that actually determine where and when the loading and unloading occur. The necessity to slide is essential. This also describes clinical situations if you put it into context. So if I take a look at the condylar path where the joint is actually unloaded, there are several things that come into play. One of them is related to muscle activity. Here's a paradox for you. I can resolve the paradox, and I will do it in a later lecture. But when all the teeth hit, the muscle activity is the highest. And that is where the joint is unloaded. Think about that. Muscle activity is highest where the joint is unloaded. When the joint is on the path in a loaded position, the EMG is the lowest. I want you to think about that because currently it is a paradox. I will be able to resolve that paradox. Again, re-emphasizing it, it describes the difference between the role of teeth as well as the role of the condyles. In the centric relation paradigm, where we're using this as a treatment parameter, again, we call the teeth and the condyles, when we marry the two together as a treatment modality, so making centric relation and the tooth position coincidental, we call the condyle the posterior determinant of occlusion. In essence, the condyle is not the posterior determinant of occlusion. The teeth are. The condyle is the stabilizer as soon as we depart from intercuspal position. In other words, the condyle is the stabilizer of dynamic and static movements when the teeth are apart. The teeth are the posterior determinants of occlusion, and when all our teeth are together in the intercuspal position, again, EMG is the highest and the joint is protected. Interesting. There's also a difference between working side, in other words, your chewing side, and the side that you don't chew on. The side that you do not chew on, which is sometimes called non-working side or balancing side, is more loaded than the working side. And the EMG on the non-working side is lower, and these are often the joints that fail first. It is the non-working side, or what we call the balancing side also, and the EMG is lower. So the lower EMG may in some regard have a predisposing component that could, under the right circumstances, contribute to joint failure. And here is the relationship that talks about maximal bite force, EMG, and vertical dimension. If you open up the vertical dimension, your bite force increases and your joint loads increase, but your EMG goes down. It's been done by many people. It is not a mistake. And so here, just as a recap, I'll say it again. When the EMG is higher, the joint is protected. When the EMG is lower, the joint is relatively loaded and somewhat unprotected. here are some of the articles that I used in order to be able to explain some of the things that I'm talking about today. And so, if I want to discuss and tell you what muscle actually does this, I'm going to replay this again just so you can see the motion. It's a rocking horse type of motion that occurs around the joint and the movement of the mandible. And here it is. This is what's described in some of the literature. It is the temporalis muscle that mostly is responsible for this. This is the fan-shaped muscle that has attachments in some of the reported literature to the disc. It also has attachments into what's called the coronoid process, which is forward of the jaw joint itself. And here it is, working like a rocking horse. And here are some articles to substantiate it. I could pick a number of them. This is Kulstra's article. Ito has talked about it. Langenbach, who you're going to see, Alan Hannum, who is a collaborator often in these things, Blanksma, Van Eegen. There's just a lot of them. And so I will conclude with this segment. I know it was a lengthy one, and pick up on this slide the next time when we talk about where disc displacement probably actually comes from. I'll be rocking it out with jaw talk, and we can finally get to the bottom of this whole thing. Thanks for joining me today, and I hope you'll join me to the next segment of Jaw Talk.